The next part I would like to share with you is the lesson that we have learned from uncertainty. First is, for our uncertainty, you should listen to patients and colleagues. Why? Because this is the example. This is the first case in the world of a typical avian influenza that the patient has really no respiratory symptom. They have diarrhea, and all of a sudden they have rapid progressive pneumonia. And why I think of avian influenza? Just because the patient relative told me that is this patient has avian influenza or not. I asked her why. She said, well, at his house, there's a fighting cock. You know, the behavior of the fighting cock is that people always have chicken fighting and they bet the money. If they win, they get a lot of money. So during the round 1, round 2, they blow up the air to the nose of the chicken. So they expose to secretion of the chicken. And clearly, because of that, they got avian influenza. I listened to that. I submit the lab, and the patient turned out to be a typical case of avian influenza. This is the first case in the literature. But the consequence is huge because no one really think that this patient had avian influenza. So a lot of healthcare workers do expose to this case without any protection. And of course, when you did not protect, you have a risk for having avian influenza among healthcare workers at least for 5 days. And we submitted the lab for anti-H5 antibody to the US CDC, and none of them have anti-H5 positive, which imply that human-to-human transmission of avian influenza still occur fairly uncommon. And of course, the data that we contributed has been included in the New England Journal of Medicine review article on H5N1, suggesting the same thing that I just mentioned, that the risk of the human-to-human transmission, particularly for healthcare workers that caring for H5N1, is still fairly low. The next lesson learned that I learned from uncertainty is to always try to convince your peer to do a good job. And my colleague is Dr. Sanjay Sen, who is an expert in the implementation science. He suggests me that, well, just read his article. There's a technique that you should use to convince the surgeon, because the surgeon typically don't listen to infection control. They don't follow the infection control guideline. So motivational interview is the technique to change behavior rather than telling the surgeon what to do. Help the surgeon see the rationale on what to do and changing the behavior themselves once they see the evidence that you put for them. And clearly, motivational interview is used in clinical pathology, psychology to change the behavior of patients and doctor. And the example is very clear. When you would like the patient to stop smoking, when you like the patient to stop alcohol, you use the motivational interview to do that. But before I tell you what is the motivational interview, you just explore yourself first, the way you talk to your child. For example, you see your child did not have a good grade. You told them, you need to study more. You see your child talking or playing telephone too much. What you tell them? You are on your phone too much. And stop teasing your sibling. Will your children follow you? Probably not, because this is very offensive. And even my spouse talking to me, you drink alcohol too much, please quit. Am I quit? Probably not, because I don't like it. And also, you gain a lot of weight. You need to exercise. So what the hell you are telling me? So you watch too much TV. So, well, good, but I don't like the way that they speak to me. Likewise, the surgeon is also the same human being like us, and they don't like the language like that. And the technique of motivation interview is introduced to change behavior. And the key technique is that first asking an open-end question to obtain their thought and feeling on certain topic that I will give you example later on. And then listen carefully to them without any judgment and without hope that they will follow your guideline and your suggestion. And then once they open their mind, we can provide the new information with the insight on the problem, with a possible solution, and let them decide themselves whether or not what they should do. And clearly, this technique has been used to help people stop alcohol. If you use motivational interview 3 times, typically it will associated with the success, but beyond 3 times is likely shown to be fail. And I would like to give you an example of this. The surgeon resists to CAUTI that in the article by my colleague Sanjay Sen has introduced the example for you. First, the surgeon never follow any guideline on the UTI as you imagine. So CMO called the surgeon, come and say, well, thank you for the meeting. I guess you have been having some trouble with the CAUTI initiative. Do you want to tell me about it? The surgeon said, well, I really discussed and I have been ordering folic for 25 years and never had a problem. Now, all of a sudden, they come up with this new regulation and it can throw you off the game. As far as I'm concerned, it ain't broke. Don't fix it. And pity for the poor resident who are supposed to unlearn what they have just been taught. The CMO responded in the way that you're really frustrated about this. And what else bothering you about this new initiative? So they explore the surgeon even more. The surgeon saying that, don't get me started. All these people telling me what to do. The surgeon don't like that. Just my wife tell me to stop alcohol. I don't like that as well. So I have got nursing telling me when I should and should not order the Foley catheter, or I should not have it taken out. Give me a break. I inserting the Foley catheter for 25 years. CMO say, well, what do you think about the science behind the initiative? Open-end question. And the surgeon say, well, that is another thing. They keep coming up with the new quality project, and it's just like a business of them. And a couple of years later on, they change their mind. This is probably another thing. And anyway, of the first about a little old UTI, we are about saving life. UTI doesn't really matter. CMO say, well, I hear you. You are quite frustrated to keep getting hit with these changes. And I really appreciated how open you are with me. And one thing though, can you tell me whether your opposition to the initiative is making things awkward for your colleague? The surgeon said, well, maybe a little bit because of the younger surgeon, maybe a little bit, and also some of the nurse, particularly the doctor who run the initiative, along with the infection control girl who are getting annoyed with me as well. And CMO said, well, you seem to be saying you feel a little bit uncomfortable about it, right? Surgeon said, well, as a matter of fact, they are pretty committed to making changes and they are not totally stupid. So this means that they start to open their mind. So the CMO start to say that, well, speaking of that, I just have a new data. Would you like to hear about it? And the surgeon said, well, okay. And then CMO said, well, there's a meta-analysis in Geneva and Bangkok saying that there are some evidence-based practice that hospitals are doing it right now. It's the same thing. And the population is fairly the same as well. And it's helped reduce UTI significantly. Did you know that CAUTI in the surgical unit is really high last month? The surgeon said, no, I don't realize about it. I guess something have to worry about that as well. CMO said that's one thing. You might consider that hospital accountants are all making the patient happy. And UTI may not kill people like you just mentioned, but it sure make them unhappy for a while. Plus, we gotta use antibiotic. This may lead to C. difficile that can kill them as well, particularly older patients that you operated on. And surgeon said, well, okay, I probably have to give in sooner or later. This is just an example of how people interact, how people should talk to each other to have them comply with the infection control policy. The next uncertainty that is the lesson learned is that uncertainty may lead to inability to stop some unnecessary infection control practice. Did you really realize that what we did in our practice did not get along with the evidence base as well? And at least there are a book written in the United States and is also making in the New York Times that researchers identify nearly 400 common medical practice and theory that were contradicted by rigorous studies. And clearly we did not do according to the evidence base. But the point that I would like to mention is that when you would like to stop this practice, it takes significant amount of effort, similarly to the way that you want them to do the practice, and this is the side called the implementation science. They are typically the barrier to stop non-evidence-based IPC practice, and these occur when the doctor get learned when they are young, and it's very difficult to stop. Second, the doctor don't really believe in the new data because the data is just published from the West, from the United States, and it may not be applied to Asia. And also sometimes a new training is necessary to implement a new measure. Of course, there are many examples of the implementation science. In the United States, they stopped doing contact precaution for MDR pathogens, which has been an evidence-based, but if you want more detail, because I have limited time, I cannot elaborate this work. And also, many countries in Europe now found that a water source has a clear link of the MDR pathogen to the patients. This is the form whole genome sequencing, that leading to the concept of the water-free patients care zone in the ICU, that in the ICU in many European countries, they don't have the water sink, because water sink has closely resembled the strain of MDR pathogen, and they did the study in multi-center and in the ICU, and they found that there is a significant drop in the MDR pathogen after introduction of the water-free area care zone. The lesson learned from uncertainty is you have to be mindful with your practice. Thinking Fast and Thinking Slow is the book written by Dan Kahneman, who is the Nobel Prizer. He is an economist, macroeconomist, who do experiments, many experiments for 10 years. And he come up with this book. To make it brief, he's mentioned that there's two systems of thinking in human. First is fast system. For example, patient went to ER. What do you think he will receive? Foley catheter, IV, oxygen, automatically without thinking. But that may not be necessary at all. But the second system, it requires thinking slow. It means mindful. You have to be a little bit slow. The patient is needed for intubated. The patient is needed for Foley catheter. Is the patient need to have Foley catheter today or the next day? This is requiring the slow thinking or mindful thinking as well. Because the healthcare-associated infection, the science is very straightforward. For example, if you want to prevent catheter-associated UTI, you have to have a clear indication of how to insert it. You have to maintain the catheter well, you have to remove it quickly, and also you have to prevent the catheter replacement to prevent catheter-associated UTI. This is relatively simple, but why people don't do it? Because they are not mindful. They are not thinking about it. They're thinking fast. They did not thinking slow. And this is why the investigator at University of Michigan Ann Arbor come up with the mindfulness-based strategy at the bedside where they are evaluating that if the patient inserting the catheter, it will be very painful. The patient may not like it, and they clearly know the pro and con for inserting the catheter, and they clearly know the indication, and they clearly know the risk of Foley catheter, and they clearly know the alternative. So these require a step of mindfulness-based approach. And again, the last lesson that we have learned from uncertainty is to have a joy in healthcare. And why I say that? Because burnout is widespread, particularly among those who are in the mid-career. And burnout is the state of the mental and physical exhaustion caused by one professional. And if you talk to yourself, you talk to your colleague that I feel burnout for my work, or I have become more callous toward people since I start this job, it implies that you are already burnt out. So this is a clear indicator of the burnout. And burnout is really a significant problem in Asia. In the last 6 months, we have in the newspaper the trend of the new generation that would like to quit from being a doctor with a working hours, and particularly in some countries like Japan, burnout is a significant problem. Why? Because in Japan, they have rooted in a deep cultural value of hard working. They have a high degree of stress, and majority of the doctors in Japan would likely die because of heart attack and stroke. This has been well evident in some article that listed in here. Burnout is a significant problem for nurses in Thailand. Before the COVID, there's a survey that Thai nurses burn out about 32%, where in Asia, the rate of the doctor and nurses in ICU burn out approximately 50% in Asia. And likewise, the evidence that we have during COVID-19 suggesting that the ICN do burn out approximately 30% as well. So clearly, burnout is a significant problem. Thus, in addition to being mindful, the awareness that arises by paying attention on purpose in the present moment is very important. And a brief mindfulness intervention showing a promise in improving healthcare worker well-being as well. And clearly, it is a predictor for personal accomplishment domain for the Thai ICN as well. Lastly, I would like to share with you a book of joy that I would put into PowerPoint, and this book is the conversation between Dalai Lama and Archbishop Tutu, and what they say is that when you are pursuing happiness, you are not going to find it because happiness is very elusive. But rather, you should make a cause for happiness. There are 3 factors of increasing joy in your life. First is your ability to reframe the situation in a more positive way. Secondly, is your ability to experience gratitude for your work, for your patient, for your colleague. And lastly, it is your choice to be kind and generous to everyone and your colleague. And these are the factors of joy, and you are the one who choose to do it. And interestingly, they mentioned that if you string together the moment of joy, joy, it will be equal to happiness. So if you want happiness, that is the thing that you have to do, the factor for improving joy in your life. Last but not least, I would like to say that the quote from Dalai Lama that in fact taking care of others, helping others, ultimately is the way to discover your own joy and to have a happiness in your life. I would like to thank you very much for your attention. ขอบคุณครับ